Good evening, everyone. My name is Hetal Gohil, and I represent the Medical Services Department. It is my pleasure to welcome you all for today's much awaited webinar on Resmetirom reverses the MASH. As you are aware, metabolic dysfunction associated steatohepatitis or MASH is a progressive form of metabolic dysfunction associated steatotic liver disease or MSLD, formerly known as NFLD, which affects 30% of adults worldwide and approximately 7 to 55% of Indians. MASH is strongly associated with obesity, type 2 diabetes, hypertension, hypothyroidism, and dyslipidemia. Unfortunately, the condition is often asymptomatic or vague in its early stages, making early detection and treatment, particularly in fibrosis stages F2 and F3, critically important to slow down the disease progression and prevent the irreversible liver damage. Despite the extensive global research, there is a critical unmet need for the effective therapy of MASH and advanced fibrosis. We are pleased to provide access to a groundbreaking liver-directed oral therapy for MASH with moderate to advanced liver fibrosis, that is Resmetirom, which helps in reversing MASH. Resmetirom represents a new era in hepatology and advanced evidence-based targeted therapy that offers better clinical outcomes and renowned hope for patients who are suffering from this progressive disease. Resmetirom is the first US FDA approved drug for non-cirrhotic MASH with moderate to advanced liver fibrosis. It selectively targets THR beta receptors, which are present in liver hepatocytes responsible for regulating lipid metabolism. This is significant milestone for millions of Indian patients who have long awaited an effective therapy for MASH. Resmetirom stands as a testament to our continued commitment in bringing science closer to the society. To explore this important topic in depth, it is my great honor and privilege to introduce our esteemed speaker for today's session, Dr. Akash Shukla, sir. Dr. Shukla is a director and consultant in Department of Hepatology at Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. He has 20 plus years of expertise in the field of gastroenterology and hepatology. He has authored over 86 original papers and is known for teaching and mentoring young gastroenterologists and hepatologists for last 15 years. His papers have won the Plenary Award at Asia Pacific Association for Study of Liver in 2018, Best Research Paper Award at Waldeck, Switzerland 2016, and multiple national awards. He has written textbooks on jaundice and NFLD. He is the first non-European to be nominated to the Steering Committee of Vascular Liver Diseases Interest Group ASID and has written the Asia Pacific Guidelines for the Management of Budd-Chiari Syndrome. He has also been the part of authoring several international and national disease management guidelines for various liver diseases such as acute liver failure, acute and chronic liver failure, nutrition and cirrhosis, hepatitis B, C, NFLD, etc. He has also been a governing member of INASID. He has worked extensively in the field of organ transplant and currently holds honorary post of Joint Director in Charge Roto Soto West and Maharashtra and Joint Secretary ZTCC Mumbai. We are truly privileged to have Dr. Akash Shukla sir with us today. With that, I would like to hand over the session to you, sir, and I sincerely thank everyone who has joined us today. Thank you. Over to you, sir.
Thank you, Dr. Hetal. Thank you, Hetero, for this wonderful opportunity. And without wasting much time, I will go on to my presentation. Are my slides visible?
Yes, sir.
Okay. Are they moving now?
Yes, sir.
Okay. So in June 2023, the terms NAFLD and NASH were replaced with the term MASLD, and it was thought that the term non-alcoholic did not accurately capture the cause of the disease, because most of these patients actually have metabolic dysfunction and obesity, diabetes, dyslipidemia, and therefore it should be more appropriately labeled as metabolic dysfunction associated steatotic liver disease. And NASH, that is steatohepatitis, would be relabeled as metabolic dysfunction associated steatohepatitis. This is the classification which we have been seeing for last 1 year, where we talk of MASLD, which could be MASL, which is just steatosis, or MASH, which is steatohepatitis, or it could be a combination of alcohol and metabolic dysfunction, which is what we call as MET ALD. And if it is more of metabolic dysfunction, then we call it MASLD predominant. If it is more of alcohol related, then we call it ALD predominant, depending on the weekly alcohol intake. Then we have alcohol associated liver diseases, which is also a steatotic liver disease. And then we have specific etiologies like drugs, monogenic disorders, etc. And finally, despite all this, you'll have a cryptogenic group. We have defined criteria now for this MASLD. For adults, it is based out of the usual components of the metabolic syndrome, the BMI, sugar, blood pressure, triglycerides, and the HDL cholesterol. For pediatric, it is based on the BMI, waist circumference, sugars, blood pressure, plasma triglycerides, and plasma HDL or lipid-lowering agents. Now, this is a very important slide for me when I look at how does a fatty liver progress. So from a healthy liver, which contains less than 5% of fat, almost one-third of the population would develop steatosis, which is fat in the liver, which will be more than 5% fat in the hepatocytes. Of these, 20%, that is every fifth individual, will have not just fat, but also inflammation, ballooning, and fibrosis. This is called as NASH. The fibrosis will progress from F1 to F2 to F3, and then in almost 7%, it will progress to the stage of cirrhosis. And then 1 to 2% of these are going to develop hepatocellular carcinoma. A very small proportion of people will develop HCC without developing cirrhosis in these patients. And therefore, the endpoint is either liver transplant or death of the individual. Now, what drives this progression? Why not everybody who has got a fatty liver develop cirrhosis or HCC? So there are certain risk factors. And if you look at the risk factors, other than the metabolic syndrome components, you have hypothyroidism as a very important parameter. If you look at the other things, they are all part of metabolic syndrome: obesity, unhealthy diet, sedentary lifestyle, dyslipidemia, type 2 diabetes, insulin resistance, hypertension, PCOD, etc. But hypothyroidism is an important cause of progression of MASLD. Why do patients of fatty liver die? In fact, the commonest cause of death in a patient with fatty liver is cardiovascular event. The second commonest cause of death is a non-liver cancer. And only the third commonest cause of death is liver disease. And therefore, it is very important that whatever we do, we assess whether these patients are at risk of dying because of cardiac ailment, cancer, or because of the liver disease. And accordingly, my choice of therapy is going to change. Whether I'm going to target metabolic syndrome and cardiovascular events, or I'm going to focus more on preventing non-hepatic malignancies, or I'm going to give pharmacotherapy and try to prevent liver-related death. The goals of therapy change as the fibrosis progresses, and once the patient reaches F2, F3 fibrosis, my job is now to ensure that this fibrosis reverses and we also prevent the progression of the disease. So not just preventing the progression, but also reversibility becomes an important endpoint in patients who have F2, F3 fibrosis. Or similarly, once it is F3, F4, then you want the patient not to develop complications of cirrhosis and reverse the fibrosis if possible. So once patient has developed fibrosis, the emphasis is not just on subsidence of the inflammation, but the goal of therapy changes to reversal of fibrosis. When I look at my patients, I would want to classify them into two groups. Whether my patient has a predominantly metabolic NASH, which is insulin resistance like NASH, or whether they are predominantly genetic NASH. So metabolic NASH are the ones who have very high insulin resistance. They have very strong genetic predisposition for insulin resistance. They have gut microbiota dysbiosis, inflamed adipose tissue, diabetes, and they are at high risk of dying because of cardiac illness, chronic kidney disease, and cancer. While I have another group of patients who are genetically predisposed to NASH much more than the metabolic syndrome. These patients have low levels of insulin resistance. They have less genetic predisposition to insulin resistance, but have a higher genetic predisposition to liver diseases. They have less frequently seen to have type 2 diabetes, cardiac disease, or chronic kidney disease. But these are the ones where the patient is going to progress very rapidly to cirrhosis and HCC. So the metabolic NASH are the people who have very high BMIs, have diabetes, have obstructive sleep apnea, but they do not have very aggressive liver disease. On the other hand, the genetic NASH are the people who have not very high BMIs, do not have morbid obesities. They are mildly overweight or normal weight, but they have fatty liver, which progresses very rapidly to cirrhosis and HCC. So, what is the role of the thyroid hormones in the pathophysiology of MASLD? So, in the liver, the thyroid hormones they regulate the energy and metabolic homeostasis by modulating the export of lipids from the hepatocytes into the bile and the bloodstream, as well as their oxidation. Also, they regulate the de novo lipogenesis, which is basically production of fat from excessive raw materials like proteins and carbohydrates and fatty acids. These hormones also control the sensitivity to the hepatic insulin and they suppress the hepatic gluconeogenesis. So they would also ensure that the less amount of sugar is formed by the liver and released into the blood. In patients with MASH, there is an alteration in the normal thyroid activity at the receptor THR beta in the liver, and this phenomenon is called as hepatic hypothyroidism. And this plays an important role in the development of MASH. We are all aware of the feedback by the thyroid releasing hormone to TSH, to thyroxine T4, T3, and the negative feedback to the hypothalamus and anterior pituitary. But what we really don't talk about are what are the terminal receptors of these thyroid hormones. So you have THR alpha, which is present in most of the organs of the body. On the other hand, you have the THR beta, which is more specific to the liver. So the T3 will enter the cytoplasm and then get into the nucleus where it is going to join the THR beta, coenzyme A, and it will also join the what are called as the RXR. And once they do that, then they are going to inhibit the core, which is the co-repressors. And this would then stimulate the T3 responsive genes, which is responsible for the transcription and translation of the proteins. So if you are interested in knowing the more details, this is how it works. But it suffices to say that the THR beta tissues are liver, adipose tissue, and pituitary. And they regulate the metabolism of fat in these organs. And that is why you require this to be targeted when you're using a therapy for treatment of MASLD because the problem happens in the adipose tissue and the liver and in the negative feedback. Now, with that background, let's see how do we diagnose NASH today. So, for the assessment of fibrosis, we use the APRI or the FIB4. A FIB4 score of more than 1.45 suggests that there could be significant fibrosis. A less than 1.45 rules out advanced fibrosis. So, two simple tests, APRI and FIB4. APRI less than zero point 0.5 rules out advanced fibrosis, and more than 1.5 suggests cirrhosis. So, all you need is SGOT, SGPT, age of the patient, and the platelet count to calculate these scores. What are the other signs that the patient may be having advanced fibrosis or cirrhosis? If the patient has platelet counts less than 2 lakhs, GGT is elevated in the absence of alcohol consumption, if you palpate the liver and it is firm, if the SGOT is more than the SGPT in a patient with non-alcoholic fatty liver disease, and in all these patients, the moment you get any of these red flag signs or your first level non-invasive test, the APRI and FIB4 are negative, or sorry, are indeterminate, you must go to level 2 of non-invasive test to confirm. So what are these level 2 NITs? We have transient elastography, which is extensively validated in over 13,000 examinations over 5-year period and is the most well established. So the FibroScan is the one which is the prototype, which was the innovator, and now we have others as well. The current non-invasive gold standard is the MR elastography, and it has got a AUROC of more than 0.9 for detecting more than F1 fibrosis. So it is very reliable. But a word of caution here, for both FibroScan and MR elastography, remember that there could be variations. So of up to 20% in a day. Therefore, you cannot depend on it for minute variations or for very accurate diagnosis. But it roughly tells you where does your patient belong, F1 or F2 or F3 or F4. Of course, the gold standard is the liver biopsy, but it has its own complications. It is prone to the sampling error, it is costly, and it is not feasible for majority of the people. So today, once I have a patient who is at risk for MASLD, I identify based on the risk factors like diabetes or insulin resistance, obesity, cardiometabolic risk factors, or ultrasound report showing fatty liver, or the patient comes to us with SGOT, SGPT. The first thing that I do is I rule out other causes. We take a detailed history for risk factors. And then, of course, we are going to manage this patient holistically by targeting obesity and the comorbidities. But for the liver, I would do a non-invasive test like FIB4. And based upon FIB4, I would classify my patient as low risk for fibrosis, which is FIB4 of less than 1.3, and liver stiffness on FibroScan less than 8 kilopascals. Intermediate risk for fibrosis, which is FIB4 of 1.3 to 2.67, which is equivalent to liver stiffness of 8 to 12 kilopascals. And high risk, which is FIB4 more than 2.67 or liver stiffness more than 12. Now for comorbidities, I'm going to manage very aggressively with GLP-1 or SGLT2. And in patients who are at intermediate or high risk, I'm going to use pharmacotherapy because this is the group of patients where my target is to reverse the fibrosis that has already set in. Bariatric surgery can be offered across the stages. So if you look at the fibrosis-based algorithm, when there is no fibrosis, you do not require pharmacotherapy. You require lifestyle modifications and management of comorbidities. You may offer bariatric surgery, because this patient is not going to die because of liver disease, but he is going to die because of coronary artery disease or cancers. Once the patient comes to stage of fibrosis, then the chances of dying because of liver disease and because of other causes is equal. And therefore, in this group of patients, I would want to start pharmacotherapy. Now, which are the drugs for which there is good evidence? Vitamin E, pioglitazone, saroglitazar, and resmetirom. Of course, there are other drugs which help the liver, but have not been approved or recommended in guidelines for reversal of fibrosis. Once the patient has gone into cirrhosis, then the patient is very likely to die because of liver disease. And there, the pharmacotherapy so far has limited role. And the main goal of therapy is to treat the complications and prevent HCC and portal hypertension management. We are all aware that the management of MASH includes weight loss and management of obesity. We know that 7 to 10% weight reduction for MASH results in NASH resolution and fibrosis reduction in a significant proportion of patients. So, exercise, both cardio as well as muscle training, are important, and at least 250 minutes per week of moderate intensity exercise is ideal for these patients, but at least 150 minutes should be performed to treat patients with MASLD. Of course, for those patients who already got cirrhosis, the diet has to ensure that there is no sarcopenia, they don't lose muscles, and a high protein diet, late evening snacks are recommended. For patients with compensated cirrhosis and obesity, it has to be customized according to the patient's demands and his profile, and accordingly, you advise. Smoking and alcohol have to be prevented at all costs. There are several drugs which have been tried, and there's publications. Semaglutide, you have obeticholic acid, efruxifermin, which are both FXR agonists. Of course, obeticholic acid has not been given approval, and we have all seen the problems with obeticholic acid. Efruxifermin data appears very exciting. Semaglutide again is very good drug for management of obesity and metabolic complications. It suppresses appetite, causes a significant weight loss, and improves diabetes control by enhancing endogenous insulin production. Then you have saroglitazar, which has been available to us for many years, which has been a boon. We know that improves insulin sensitivity, improves lipid profile, improves the beta oxidation by activating PPAR alpha gamma, and is known to cause good amount of NASH resolution. In addition, you have pioglitazone. Elafibranor has been a negative trial. Then you have SGLT2 inhibitors, which are used to treat diabetes. They also help in managing the MASH. Then you have other drugs like antioxidants and vitamin E, for which good amount of data is available. For statins, I think it has been found that they are not dangerous to the liver. If at all, they are friendly and helpful and improve the liver outcomes. Bariatric surgery at all stages is useful except for patients who already got decompensated cirrhosis, and it is known to not only improve the metabolic control but also reverse fibrosis in a significant proportion of patients. What do the ASLD guidelines tell us? It tells us that there should be a multimodal approach which should comprise the endocrinologist, the gastroenterologist, hepatologist, and a nutritionist. And along with that, there should be cardiology, management, weight management, and health psychologist. They should all come together to manage this NAFLD patient. The current gaps in therapy are a lot. We Today also we advise lifestyle modification, but only 7% of people actually follow it. The drugs which are available are not extremely effective, and they have come with their own problems. Semaglutide has resulted in good amount of MASH resolution without worsening of fibrosis, but again, the long-term safety data is not yet available, and we are also slightly concerned about the impact on fibrosis, which has not been as robust in some of the trials as the pivotal trial. And therefore, in USA today, there are no approved pharmacological agents specifically till Resmetirom got the approval. And in patients with NASH, the THR beta signaling within the liver is diminished, and there is impairment of the metabolism, fatty acid oxidation, energy production, and this results in worsening of NASH and liver fibrosis. To add to it, the lipotoxicity, because of reduced conversion of the prohormone T4 to active hormone T3, is also contributing to the progression of liver disease. And therefore, there is a need for liver-directed therapy in the management of NASH, which is not yet available to us. And therefore, resmetirom got the approval by US FDA in patients with non-cirrhotic NASH with moderate to advanced liver fibrosis. So it is a oral thyroid hormone receptor beta agonist, and it is developed to target the key underlying causes of MASH. It got approval in March 2024. It is also under regulatory review in the EU. It can be taken with or without food, and the dose is weight-based. It is indicated in conjunction with diet and exercise for the treatment of adults with non-cirrhotic NASH or MASH with moderate to advanced liver fibrosis, which is basically saying consistent with stages F2 to F3. Now, this does not mandate a biopsy. This may be diagnosed on fibroscan or elastography. And what the ASLD tells us is in those patients who have a liver stiffness measurement of up to 15 kilopascals, it should be given. Between 15 to 19 liver stiffness, it may be considered with caution, but should not consider it once you touch 20 kilopascals. It should definitely not be given to patients who have decompensated cirrhosis because it itself has some potential for hepatotoxicity, and in decompensated patients that can cause very sudden worsening. What is the dosage? For those people who are less than 100 kgs, 80 milligrams once a day. For those who are more than 100 kgs, it's 100 milligrams once a day. If the patient is on drugs like clopidogrel, then you reduce it to 60 milligrams from 80 milligrams for less than 800 kg. And for those who are more than 100 kg, you come down to 80 milligrams once a day. How does it act? It is a partial agonist of the thyroid hormone receptor beta, and it inhibits activates it directly in the liver. It has a 28-fold higher affinity over THR alpha, and this drug basically binds to the receptors in the liver and causes the beneficial effects, and the actions outside the liver are minimum. And this drug can achieve almost 84% of the maximum activity that T3 actually achieves. So in patients with MASLD, you have impaired thyroid hormone function, and this thyroid hormone, which regulates the mitochondrial functions and the hepatocytes, and the low thyroid hormone function can cause accumulation of lipids in the liver and also cause mitochondrial dysfunction. And this contributes to development of MASH and progression of fibrosis. So resmetirom actually targets this. It activates the THR beta signaling. It improves the lipid metabolism. It improves the performance of the mitochondria and thereby reduces the oxidative stress in the hepatocytes and reduces inflammation, thereby reducing the risk of fibrosis and reversal of fibrosis. So reduces steatohepatitis, reduces fibrosis, and outside the liver, it would reduce the levels of triglycerides, LDL cholesterol, ApoB, lipoprotein B, and improves the insulin sensitivity. And therefore, you get benefit not only in the liver, but in the other tissues as well. In the liver, it also suppresses the de novo lipogenesis and reduces fibrogenesis. So, if I summarize summarize, what are the actions in MASH? Decreased liver fibrosis, improved cardiovascular outcomes, and enhanced health-related quality of life. The oral bioavailability is 45%. The Tmax is 4 hours. A word of caution here, it is metabolized by CYP2C8. Therefore, all other drugs which are metabolized by CYP2C8, you have to be very cautious when you're combining the two. And we'll just talk about it in the subsequent slides. The elimination half-life is 4.5 hours, and it's predominantly in the feces and small amount in the urine. It should not be given in pregnancy and lactation, pediatric population, patients with severe renal impairment, or in those undergoing dialysis, and in patients with decompensated cirrhosis. What are the common side effects? Hepatotoxicity has been reported, and elevations in SGOT, SGPT were noted in the initial 4 weeks of starting this therapy. And if hepatotoxicity is suspected, you should immediately discontinue resmetirom. Then you can have risk of gallbladder-related adverse reactions, and it has a very significant interaction with statins, and therefore dosage adjustments are required when the patient is on concomitant statins. In patients with severe renal impairment, which is CKD grade 3 and above, it is best avoided. In hepatic impairment, no dose adjustments, but you should not use it in patients with CTP B or C or decompensated cirrhosis. Should not be used in pregnancy and lactation or in pediatric population or geriatric population above 65 years of age. We do not have any safety data, but it appears to be equally effective. Now, what about drug interactions? So it's a CYP2C8 substrate, and therefore drugs which are also utilizing this CYP2C8, you have to be very, very cautious. And you have to reduce the resmetirom dose if you're giving it with the CYP2C8 inhibitor, classical example being clopidogrel. What about OATP1B1 or OATP1B3? It is also, again, a substrate for these receptors. And therefore, if you're using other drugs which use OATP1B1 or OATP1B3, then we should not be using resmetirom along with it, the classical example being cyclosporin. If you're giving along with statins, then rosuvastatin and simvastatin should not be given beyond the dose of 20, and pravastatin and atorvastatin should not be given beyond the dose of 40. And if you're giving along with the other CYP2C8 substrates, then the patient should be very cautiously monitored. The most common side effects are diarrhea, nausea, vomiting, constipation, abdominal pain, pruritus, and dizziness. But by and large, the drug was very well tolerated, and these side effects were not much more common than the placebo. There were no serious drug-related adverse events in the pivotal trials. So if you look at the guidelines, these are the EASL, ESD, EASO guidelines. They recommend that when you're targeting MASH, if locally approved, then resmetirom should be used in patients with F2, F3 fibrosis, while the other drugs like GLP-1, RAs, SGLT2 inhibitors, metformin, insulin, statins, etc., are useful for treating comorbidities, while they also have a beneficial effect on the liver. And when should you use it? In patients who have F2, F3 fibrosis, along with steatohepatitis. So these are the patients where it is worth the risk because there is a small amount of risk of hepatotoxicity, and therefore you have to be careful and monitor this very closely when you're starting a patient on resmetirom. Remember, the algorithm for resmetirom is not just starting the drug. It has to be along with a lifestyle intervention. So diet, exercise, and the drug is what is required. Also, not just diet and exercise, but also close surveillance is also needed once you start the patient on therapy. And if you get the good clinical response, if you get biochemical response, fibrosis reversal, then you can continue the therapy beyond 12 months. Otherwise, you should terminate the therapy if you don't get the desired results in 12 months. So we would do regular assessments for thyroid function, lipid profile, and for efficacy, we would always do liver stiffness assessments either by elastography like FibroScan or MRI PDFF. And it should be done at least once a year, while safety assessments we would usually do every 3 months. So, what are the treatment outcomes? If you find that the non-invasive markers of disease activity are not improving, like FIB4, EPRI, or S transaminases, then we should stop the resmetirom at 12 months. If you find that there's improvement in the liver stiffness by at least 25%, or MR elastography by at least 20%, or there is normalization or significant improvement in the ALT, then we must continue resmetirom. If some patients have responded in between, then we have to be reasonable. We have to discuss with the patient. We have to reevaluate the strategy and then decide whether we continue or we discontinue. This was the phase 3, the Maestro NASH trial, 966 patients, which looked at NASH resolution without worsening of fibrosis or improvement in fibrosis without worsening of NASH score. And this included fibrosis ranges from F0 to F4. NASH resolution was seen in almost 29.9% patients with resmetirom 100 mg, 26% with 80 mg, versus just 9.7% with the placebo. Improvement in the fibrosis was seen in almost 25% of the patients with resmetirom as compared to 14% with the placebo. So you have almost 11% extra advantage. So almost double the number of patients would respond in terms of fibrosis as compared to. The LDL cholesterol levels reduced significantly with resmetirom both 80 and 100 as compared to placebo. There was improvement in the triglycerides, ApoB, ApoC3, and lipoprotein A levels with resmetirom. The transaminases decreased more in the resmetirom group as compared to placebos. And the liver stiffness, as assessed by VCT or MRE, improved in patients with resmetirom. Both the dosages were effective and resulted in improvement of liver fibrosis by at least stage in 1 year. The most common side effects were diarrhea and nausea, and the incidence of serious adverse events were comparable amongst 80 mg, 100 mg, and placebo. So 11%, 12.7%, and 11.5% in the three groups. So the side effects comparable to placebo. This was the 52-week randomized trial, Maestro NAFLD-1, where the primary endpoint was incidence of treatment emergent adverse events, and the secondary endpoints were the liver, the metabolic parameters like LDL-C, ApoB, triglycerides for 24 weeks, and hepatic fat and liver stiffness over 52 weeks. So it was found that it is safe and well tolerated. Majority of the adverse events were mild or moderate. 70 patients experienced a serious adverse event. They were diarrhea, nausea, abdominal pain, and headache. Overall, adverse events happened in 86.5%, 86%, and 81% of patients. So again, it was comparable to placebo. But if you look at the efficacy parameters, there was a significant improvement in LDL-C, ApoB, triglycerides, MRI-PDFF, liver stiffness, and the MRI-PDFF at 52 weeks. It was as safe as a placebo, and this positive result reassured everybody that it appears to be safe and tolerable in patients with NAFLD. This was another study which demonstrated the fat reduction in patients with NASH, and this also demonstrated that it is associated with improvement in the quality of life. So they used the SF36 and the SF6D health utility scores, and following therapy at 12 weeks, 36 weeks, they demonstrated that there was a significant improvement in not only NASH and fibrosis, but also the health related quality of life. And this was even more in patients who had response on MRI-PDFF. Now, this was a study which looked at the meta-analysis of 6 randomized controlled trials comparing the efficacy of semaglutide and resmetirom for treating MASLD and NASH. The outcomes evaluated were transaminases, NASH resolution, fibrosis improvement, improvement in MRI-PDFF, and more than 30% fat resolution and treatment discontinuation due to adverse events. So for NASH resolution, resmetirom was superior to semaglutide. For fibrosis, again, resmetirom was found to be more efficacious. For MRI-PDFF change also, resmetirom was better. Similarly, for more than 30% fat resolution, resmetirom was superior. For AST, there was no difference. For ALT, resmetirom was slightly better. Treatment discontinuation, resmetirom had more discontinuations due to adverse events as compared to semaglutide. And therefore, it is important that we monitor the patients carefully during resmetirom treatment. So on one hand, we find that data says that the side effects are comparable to placebo, but here you have a significant number of more discontinuations because of adverse events as compared to semaglutide. So they concluded that resmetirom demonstrated higher efficacy in resolving MASH, fibrosis, and reducing liver fat. But semaglutide has definitely got advantage of weight reduction and glycemic control, and therefore we would prefer semaglutide in patients who have comorbid obesity and diabetes. If you compare resmetirom and saroglitazar, saroglitazar is primarily targeting lipid and glucose metabolism. Resmetirom is primarily targeting liver. The mechanism of action is PPAR alpha gamma for Saro, whereas it is THR beta agonist for resmetirom. Both of them reduce liver fat and inflammation and improve insulin sensitivity. In India, saroglitazar has already been approved and we have been using it for many years. We know that it is very safe. It doesn't get affected by statin therapy and has been good at NASH resolution, has not been as efficacious for fibrosis reversal. Resmetirom has been approved by the US FDA. The real life data is still not widely available and it is under regulatory review for European Union. And therefore, we again have limited data in real life with resmetirom. We know that liver fat reduction happens with both resmetirom and saroglitazar. With in terms of histological response, almost 25 to 30% achieve NASH resolution and similar number of patients achieve fibrosis reversal with resmetirom. Unfortunately, with saroglitazar, we have limited data on fibrosis reversal. Histological response, we have few studies which show significant improvement in terms of NASH resolution. What we know for sure is normalization of transaminases happens very often with saroglitazar. In fact, it's the norm rather than the exception. Common adverse events with resmetirom are GI, while with saroglitazar, it is nausea, weight gain. And the metabolic effects are mainly reduction in LDL and triglycerides, while with saroglitazar, it mainly improves TGs, triglycerides, and HbA1c, but doesn't have much effect on the LDL. So overall, resmetirom has robust large-scale phase 3 studies, but not in India. In US, saroglitazar, we have data from India, but not from other countries, and we do not have much data on fibrosis reversal. Then you can compare it with, this was a systematic review comparing it with GLP-1 agonists in MSLD and MASH. And what they found was the fat reduction was the best with resmetirom and MASH resolution was also the highest. with resmetirom, and the improvement in the SGOT, SGPT, and GGT was also the best with resmetirom. The side effects of diarrhea were much more in resmetirom and FGF21 analogs as compared to other drugs. So, if you look at the expert panel recommendations for use of resmetirom, once you confirm that the patient has MSLD and doesn't have any other cause for the liver disease, and the patient is having F2, F3 fibrosis by either fibroscan, which should be between 10 to 19.9 kilopascals, or MR elastography 3.3 to 4.9 kilopascals, or ELF score, or FAST score, or MAS score, and you have excluded cirrhosis, you must consider this patient for resmetirom. So, to summarize, my dear friends, MASLD is a very common disease which we are facing. It's an epidemic. FDA has approved resmetirom, and it is a breakthrough in MASLD treatment in the US, because now you have a drug which you can offer to patients who have non-cirrhotic MASLD with advanced fibrosis, F2 to F3. It is a liver-targeted THR beta selected drug, and it improves hepatic fat content, causes MASH resolution, but more importantly, fibrosis improvement in patients with advanced fibrosis. And it also has favorable effects on peripheral lipids, is generally safe and well tolerated, but is expected to have GI adverse events, which the patient should be mentally prepared for. Thank you very much. And I would request that all of us should join hands in fighting this deadly disease. Thank you very much. And I'll be happy to take any questions.
Thank you for the detailed discussion, sir. We will be starting with the questions. Uh, so the first question which we have received is, how long resmetirom should be prescribed and what should be the duration of treatment?
So currently we have data for up to 1 year, and therefore I think for now the prescriptions should not be for beyond 1 year till we have more safety data. And as I gave in my talk, once you have patients who have responded uh, in terms of fibrosis or NASH resolution or transaminases at 12 months, you can continue the therapy beyond that. But if the patient has not improved in 12 months, then you should not be continuing the therapy.
Okay, okay. Again, in line with the previous question, what are the specific parameters or vitals need to be monitored during baseline and during the therapy with resmetirom?
So at baseline, we would do a complete profile. The first thing is to rule out other causes of liver diseases. So you have to rule out hepatitis B, hepatitis C, autoimmune, Wilson's, but depending on the clinical setting. So you need to rule out the other causes. Then you would look at the metabolic parameters. So you look at the sugars, lipids, the BMI. You'll do a non-invasive assessment of liver uh, fibrosis as well as amount of NASH. So you would do elastography, either MR elastography or VCTE. We would do a FIB4 usually in our practice. We would do thyroid function tests, HbA1c, and once we start the therapy, then we must monitor. Usually at 4 weeks, we would do a repeat LFT. That is extremely important because the hepatotoxicity usually would happen in the first 4 weeks itself. And then at 12 weeks, 24 weeks, and 48 weeks, we would monitor for all the parameters. And at once 12 months are completed at 48 weeks, we would then typically ask for a repeat assessment of liver stiffness and the NASH activity, whatever we have used at baseline.
Okay, okay, uh, so how do you place this drug in the presence of saroglitazar, vitamin E, and pioglitazone?
So I think the disadvantage with pioglitazone has been weight gain and fluid retention, and therefore it has not really been a favorite for most of the people, despite positive study. The PIVENS trial has been there for more than 10 years now, and it has never really picked up. Vitamin E, again, you can use it for short terms, but we know that it does not reverse fibrosis. So all it does is it delays the progression of fibrosis and causes NASH resolution. Therefore, it is not a great drug for reversal of fibrosis. With saroglitazar, again, like I discussed in one of the slides, there is good data for normalization of enzymes, for improvement in the liver fat and inflammation. But again, the problem is it we don't have good data to show that it reverses fibrosis in a large number of patients. And therefore, I think resmetirom has that advantage, although it's a small one. It's not that it's going to cause fibrosis reversal in everybody. If you look at the data, it's only 25 to 27, 30% of patients who have NASH resolution and 25 to 30% who have fibrosis reversal. So, which is not a huge number, but nevertheless, it is for the first time a drug has been demonstrated to reverse fibrosis while maintaining safety. I think that to me is the key. It's the safety part which is more appealing to me than more than anything else.
Okay. So if the patient is already on the other therapies like saroglitazar or vitamin E or any other drug class molecules, then there is a need to stop all those treatment and then start with resmetirom, or you can give resmetirom
So
along with
that's
this medication.
Yeah, so I think that's a very difficult question to answer for me right now because we do not have any data on this. And therefore, whether we should continue the previous medications and shift him to a new drug, or you stop the previous therapy and start him on this, I think I don't know based on data. But what I would recommend based on my understanding is that if the previous therapy has not worked, and the patient is progressing despite the previous therapy, whatever it is, then there is no point in continuing that therapy. In such cases, you should, so progressive disease on previous therapy, you should start the patient on resmetirom and stop the previous therapy. While if the previous therapy has been effective in terms of at least preventing the progression, then you may consider to continue that therapy while you start resmetirom. But again, these are very highly personal opinions, and there is no data to back this. So I would not suggest people to just follow me. They can probably wait for the data to come and then take call.
Okay. Okay, sir. Um, so in patients with hypothyroidism, there is a need to, adjust the dosage of resmetirom along with if the patient is on thyroxine.
Sorry, I didn't get your question.
So if patient is having hypothyroidism and if the patient is taking thyroxine, is there a need for dosage adjustment of resmetirom?
So the answer is no. There is no need for adjustment, but you would monitor the TSH very very closely, and the free T3, free T4 levels, and based upon that, you're going to adjust the dose of thyroxine.
Okay, okay, sir. So how about flow chart like using lifestyle interventions, then OCA, a cheap drug, and so on, and use expensive drug, a next choice, etc. So this is the question from Dr. Anil
So I
Singh.
think obeticholic acid should not be used. I think that is a very clear data to show that this adverse events are extremely high. Both pruritus and the risk of liver failure is real. In patients with cirrhosis, you can get acute and chronic liver failure and severe cholestatic jaundice. So it is a drug which is best avoided for this indication, and that is why US FDA has not given approval, neither has Indian FDA given approval to obeticholic acid for MASH. Obeticholic acid is approved only for PBC in India or in rest of the world. So the indication for me is only in PBC, not in MASH at all. So I don't think we should even be talking about it uh, in our practice.
Okay. So there is a question which mentions that how do you distinguish patients so that you can give one patient saroglitazar and one patient you will prescribe resmetirom? On what criteria you will distinguish those patients?
Yeah, so I think it depends on what is my goal of therapy. If my goal of therapy is just NASH resolution, then for those patients, probably saroglitazar is sufficient. For patients who have significant fibrosis, you have F2, F3 fibrosis, uh, and their fibrosis reversal is my goal of therapy. There, probably I would go for resmetirom.
Okay, sir. Okay. So apart from thyroid malignancies, any other contraindications of using or starting resmetirom?
Yeah, so like I said, in patients with who have uh, advanced chronic kidney disease, so CKD grade 3 and above, patients at extremes of ages, and patients with pregnancy, lactation, these are the patients where it is absolutely contraindicated. But other than that, we do not have data on if there are any other groups which should be completely eliminated.
There is a question which states that can it take with NASH?
Sorry, Hital, I missed what you said. Can you repeat your question?
Yes, sir. So can it be initiated if the patient is having is on mild alcohol intake and NASH coexistent?
So again, we don't have data on MET ALD. The data is only for MASH. So as of now, I don't think we should be using it in patients with MET ALD.
Okay, okay, sir. Uh, if liver biopsy is required to start resmetirom or can go ahead with only fibroscan reading?
So I think this is one of those rare situations where actually the permission has been given to prescribe based on liver stiffness assessment itself in the ASLD guidelines. And if your fibroscan score is more than 8 kilopascals according to some, or more than 10 kilopascals according to some, but less than 20, then you can use resmetirom.
Okay. In which patients you will, I mean, in your opinion, which patient can be given combination of both saroglitazar and resmetirom?
I think that's a very difficult question. So we don't have any data whatsoever to say which patients will benefit with the combination therapy. Um, I think we need to generate that data from India, because if you ask me, the future of therapy for NASH is combinations. But which combination for which patient is a difficult question to answer, because we already have so many options available to us. We have vitamin E, we have saroglitazar, we have pioglitazone, we have now resmetirom, we have semaglutide, we have tirzepatide. I'm pretty sure very soon we are going to have survotide. So once we have so many options available, and then probably we'll also going to get efruxifermin or efimosfermin. Once we have all these drugs, which combination to be used in which patient, I think we are in for very exciting times, because we need to generate all this data. It's extremely
Right, sir.
unlikely that the pharmaceutical industry is going to generate this data for us. So we as clinicians will have to generate this data and find out our own algorithms for our patients. And I think this is a golden opportunity for India uh, to do this pioneering research and show the world what is the best therapy for these patients. So one question which has been asked is, apart from rosuvastatin, which are the other drugs where we have to be cautious? So drugs like
Yes, sir.
cyclosporin. Yeah.
Steatosis and inflammation, but has fibrosis progression with added. So there is a question with semaglutide actually. Can we combine semaglutide along with resmetirom?
So again, unfortunately, my answer is the same. We don't have any data on the safety of such a combination. So when you don't have safety data, I think I would be very reluctant to use combinations because you don't want surprises when you give the two together.
Right. Can it be used in geriatric patients with all the comorbidities?
So the if yeah, that's a very good question actually. So it is in patients with above 65 years of age, it has been found to be as efficacious, but the number of patients were small. So above 75 years of age, I think as of now it is best avoided. Between 65 to 75, I would suggest that use it with caution in appropriate patients with indications. Below 65, I don't think there should be any concern in using.
Okay, sir. Okay. So with clopidogrel, there is drug-drug interaction. So which are the other drugs except like statins? Which are the other drugs where we need to be careful along with resmetirom?
So along with the other drugs like cyclosporin, you have to be careful. We don't have data on PPIs, but I would be cautious in using PPIs also along with it. And I think all the other drugs which use the CYP28, I think that is the group which I would be careful about.
Okay. So there is a question which on diagnosis, is EUS guided biopsies are good enough?
So yes, I think we have done those studies where EUS guided liver biopsies are good enough in terms of length that you obtain. But we have to be cautious because the width may not be adequate, and therefore staging of fibrosis could be fallacious with the EUS guided biopsy, even when you're using 19 gauge needle. So I think while it is exciting to use this as a research tool, I think we are far away from using it in the routine practice.
Okay. Till when the drug therapy is supposed to be continued and what is the endpoint of the therapy?
Yeah, so I think we discussed this shortly before also that the therapy should be continued for a year. But if the patient develops adverse event before that, or if you find any worsening before that, then you can discontinue. If you don't get the desired results in 12 months, then you should discontinue. And you may continue beyond 12 months if you find that the patient is improving. For me, the endpoint of therapy would be if there is reversal of fibrosis and patient reaches back to F0. For me, that is my goal of therapy in this patient.
Okay. Is there any chance of relapse with the use of resmetirom?
So the answer is the moment you stop, it is all going to depend on the lifestyle of the patient. And if he continues the same lifestyle, he may have a relapse for sure.
Okay. Okay, sir. Okay, sir. Um, so how do you decide to switch or add resmetirom?
So, s- like I said, I think I addressed this before also in one of the questions. Uh, for me, if the previous therapy has not worked and the disease has progressed, then I would definitely want to switch. If the previous therapy is working, is doing fine, I don't think you should be adding. If the previous therapy has prevented worsening but not shown any improvement, I think probably you would be justified in adding.
Okay. Okay, sir. Sir, we have finished with all the queries which were asked during the session.
I
And
think it was a very good question asked by Dr. VGM. Semaglutide alone improves
semaglutide.
fibrosis and
Yes, sir. We
inflammation,
have taken
but
this
has
question.
limited antifibrotic effect. Resmetirom may enhance the fibrosis regression when added. Can we combine the two? So very sound logic, which you have said, but unfortunately, like I said, we don't have any data. and we don't have data on the safety of the combination. Therefore, I would be little reluctant to offer this combination to our patients.
Yes, sir.
I think one more interesting question is, should we be careful of gallstones and starting resmetirom? The answer is yes. The gallbladder related complications are known to happen with resmetirom, just like all your GLP-1s, so whether semaglutide or tirzepatide. So the same risk is there with resmetirom as well. And therefore, we have to be careful and watchful about these things.
Yes, sir. So we have taken most of the queries, sir. And thank you so much for the insightful session, sir. I'll hand over the session to uh, Mr. Nehru, sir.
Okay. Thank you. Thank you very much.
Thank you, sir. Thanks a lot. I think it's been a wonderful session, and in fact, we see a lot of participants in today's session. More than 600 doctors are live in attending your session, and even the kind of questions that we had seen is the common questions that even we had come across during our discussions with most of our doctors. As you said, sir, this is a golden era, golden period, I must say, when it comes to MASH treatment in India. A lot of new products are being introduced. I mean, even if you look at tirzepatide, semaglutide, and with existing pharmacological treatments, I think we are in a uh, good phase when it comes to the management of MASH. And I'm sure that in our partnership in ensuring the access of improving the accessibility of resmetirom to the Indian patients will be able to do a good justifiable job and ensure that these patients would get that medicine that is required for them. It is one of the unmet needs of the current treatment of NASH. With that, sir, I thank you for taking this session and taking time out and answering all the queries. We know that we need to do a lot more scientific programs and contents in terms of spreading more information about this particular product and answering all the queries that has been addressed, that has been raised as well. And I'm sure that in the due course of time, we'll like to organize more such programs and ensure that we have the right information passed on to the clinicians. So I thank once again all my colleagues and participants for taking your time out and being a part of this session. And we are there in touch with all the clinicians. So anytime any information and any related drug related information is required, we'll be able to glad to provide that information. Shortly, we'll be providing a website on this Resmetirom as well, which will be able to provide all your queries in terms of how exactly we need to go about the usage of this particular drug in the Indian patients. So this is an e- exciting phase for us as well, sir. So we'll ensure that we'll do whatever the best possible work that we can do in terms of providing information about this particular product. Thank you, sir. Thank you once again for joining us, and thank you for giving this wonderful session. Thanks a lot.
Thank you.